Well, hey there, Dr. Clark Damon coming to you guys again tonight, and we're going to be talking about Neoconvert, and it's a new product put out, and it has really uh, changed what we've been doing this year, and I'm really excited to talk to you guys about it. Currently, we're using this on most of our cases that are not digital. Right now, we typically like having our dual arches converted traditionally, but the Neoconvert really saves a lot of time because we don't have to drill through the denture to gain the screw access holes, and then after it is picked up to the cylinders, we don't have to go back through and re-drill everything out. With Neoconvert, we're easily saving 45 minutes on conversion time. What I want to talk to you guys about is just keeping it simple. And this Neoconvert conversion prosthesis is simple, but will allow us to upgrade our conversion prosthesis. What I have here on the screen is a Neoconvert same-day temporary implant bridge. If you look at it, you can tell that it's highly polished, very small screw access channels, and there has not been a lot of acrylic destruction. And you can tell most of the screw access holes are in the cingulum or right uh, in the tooth, and is very minimal when we look at it the old way compared to the new way. This what you see on the right with Neoconvert, that's what, 10 years ago, that's what my acrylic titanium prostheses looked like. I would consider that an amazing looking final, and yet that's just the tip. So Neoconvert is going to allow you to convert your cases faster, have a stronger prosthesis. It's going to be a better temporary prosthesis, and it's going to allow you not to have to purchase all of the digital equipment. So its use in traditional analog workflows. And if you are a clinician who has dabbled into some digital dentures, well, you can take your digital workup and your digital denture and you can analog convert this. So it allows you to skip the step of purchasing a photogrammetry device, using photogrammetry, and using intraoral scanning. So when we roll into our surgeries, especially on a dual arch, we're not having to bring all that equipment in. And you can kind of think, hey, if a case fails, or if your computer fails while you're in surgery, you're going to be up a creek without a paddle and without a ability to do some of the digital workflow unless you have some backups and some redundancies, which of course a lot of us have. But again, that just doubles the cost. And so this is simple, reliable, and it's traditional. Again, we've got the old school way on the left. That's what I used to do a long time ago. No more drilling through the prosthesis anymore with Neoconvert. No more unsightly metal cylinders. It actually speeds up a lot of our lab time as well. We limit our prosthetic temp fractures while they're in the healing phase. And again, like I've said before, I can literally hook this up in 10 minutes as opposed to 45 to 50. And look, I mean, you can tell, like, just not having those metal cylinders, it's unsightly. There's also more acrylic that's in there. The original acrylic denture prosthesis now has massive holes in it, and it's actually weakened. So it kind of it shows for itself how much better this Neoconvert is. And the beauty of this is that we can literally remove it from the patient's mouth with the snap. Very simple, very clean, very strong. And now that's ready to go to the lab. This is that digital way that I mentioned. If you are a clinician that likes to have digitally fabricated dentures, you can get your pre-op wax up and pre-operative design, mill that out. If you're going to do this, I recommend that you get a milled PMMA prosthesis. That way it's polymethyl methacrylate, so it will bond much better to this than say a printed temporary denture. Typically those are going to be brittle during this process, so I don't recommend it. So indications. Neoconvert is indicated for patients who actually have their own existing denture. So if they come in and they've got a well and a reasonable existing denture, we can get them straight into surgery without having to remake their prosthesis. Now here's what my recommendations on for that would be. One, I think the denture, the patient's existing conversion prosthesis should be less than 5 years old. It should be in relatively good fit. We want to make sure that there's adequate support and stability with the conversion prosthesis that we're going to use versus remake. So that is an added benefit. We can get them into surgery much quicker. Also, this works for dentate patients. We would fabricate them either a 3D designed milled PMMA denture, or we could have a analog workflow with alginate impressions, wax rims, and a processed and packed denture. So it works for all three of those methods. But at the end, at the end of the day, not everyone is ready to go all in on digital. We want clinicians to be all in on full arch, but not necessarily to be overwhelmed with the full digital workflow. And so if we just keep it simple, like what we talked about in one of the first slides, we can reduce our conversion time, increase the robustness of our temporary prosthesis. We have highly accurate drilling, and so that allows for very thin screw access channels, and it's an excellent clinical and laboratory workflow. Let's talk about the Neoconvert product itself. It is more than just a coping that fits on the multi-unit abutment. It is actually a system. It's based around the Neoconvert titanium coping. They come in a 5-pack, and it comes with two different options, two different height options. So we can have a 5mm height option and a 6.5mm height option. And I recommend to do the taller option because a little more of the coping is actually proud of the gingiva, and so it's easier for the acrylic to attach to it. This is only for use with the mini conical abutment. So if you're outside the US and you use the micro, this isn't going to work. This is strictly just for the standard multi-unit, what Neodent calls the mini conical abutment. The coping is held in place by what is called a Neoconvert capture pin. This is a PEEK material, and this is what essentially almost breaks away, or in this system it actually doesn't break away. When you snap it off, it just folds under, and so typically there's nothing that we have to clean in our multi-unit screw channel. But the Neoconvert capture pin comes in a 5-pack, and it works identically with either the 5 or the 6.5. So there's only one size Neoconvert pin to order. Also within the system, we have what's called the Neoconvert capture pin driver. This is a square interface that attaches directly to that Neoconvert capture pin, and that is what we screw onto our multi-unit abutments. The Neoconvert capture pin driver only will torque at about 1 to 2 Newton centimeters, and then the spring will disengage. And so it'll continue to rotate, and it actually won't ever get tight. It's a feature of this, because we're not wanting the Neoconvert capture pin to lock into the abutment with a lot of force. The system is also built around Neoconvert drills. There are two 1.5 drills, and there is one 2.0 drills. And these are what is going to develop your screw access hole that we will talk about. And the drilling accuracy of the Neoconvert drills is done by the drill guide. The drill guide fits intimately within the titanium coping, and it is an identical interface as the multi-unit abutment. And so by using this guide, it helps orient the drills to be highly accurate, so there's no deflection as we're drilling from the intaglio to the outside surface to develop the screw channel. And what's really nice about this entire system is it all can be fit into a separately purchased Neoconvert toolbox, as shown here. So let's talk about the clinical protocol. So like I said, there's really kind of 3 tracks that you can go. You can go and we can use the patient's existing acceptable prosthesis. We can go on a second track where we use traditional removable lab workflow, alginate impressions, wax rim, and then providing a processed acrylic denture. We can also go the third track, which is an intraoral scanning, digital smile design, and then fabrication of a milled denture for an analog chairside conversion. The Neoconvert is only recommended for full arch patients in immediate loading. It is only for use with the mini conical abutment. So, as we get into the clinical protocol, the surgery has been done, implants are placed, the multi-units are in, bone grafting has been done. We are now ready to suture the prosthesis, we are now ready to suture closed. In order for us to suture closed, we have to be able to trim our excess tissue, and we also need to be able to thin. By trimming and thinning, we are going to be able to get our prosthesis to seat better. We're going to be able to increase the amount of restorative space that we have. And we are going to more predictably be able to hook up all of our Neoconvert cylinders at the time of conversion. So here we are now, utilizing a 15 blade and some needle holders, performing a thinning of the palate. So we are reducing the subepithelial connective tissue. My assistants are holding the palate side with some Adson tissue forceps. And I will go in and I will grab the remainder of the tissue, and you can see that we really have, and we are going to cut off. And you can tell whenever I remove this, we are trimming it down way, way, way down at the base. So now we will go through and we'll evaluate this. What I can tell here is that the palate is still thick. So we're to continue to take a little more off. This is in that 2 to 3 millimeters of the very coronal aspect of this palatal tissue. And after we remove it, we'll just lay it down flat and make sure that it seats quite nicely. After we have trimmed and thinned our palatal tissue, I want to check that I can advance the palate to overlap to the buccal edge of my all-on-4 shelf. We are then going to use a rotary tissue punch so that the MUAs come through our tissue. And as you can tell as we go through, this is maybe 1.5 to 2 millimeters of tissue thickness. And we are able to see the very tip top of that mini conical abutment. This is a simple 4.3 rotary tissue punch that we're using here. You can use it at about 300 RPMs with irrigation coolant. A couple of fine points to note here is that the palatal tissue is now buccal to all of my multis. That is going to increase my success over the long term. It's going to resist any resorption, but also it's a very thin tissue. After that, after we have provided the tissue punch, we are going to rinse, and then we are going to suture. I recommend for you to use a 2.0 or a 3.0 chromic gut suture. I prefer the 2.0. It's a little bit thicker, and it just allows me not to break it within the mouth. I typically start at midline, and we will do a running horizontal mattress suture all the way to the posterior, and then we will then baseball that in a continuous looping suture all the way forward. So we start at midline and we end at midline, and then we'll grab a new suture, start at midline, and go all the way back. What we can appreciate here is the tautness of our tissue, and this doesn't take very long. It takes maybe 5 to 10 minutes to suture, and I'm able to see my multis. If I was not able to see my multi-units at this time, I would need to think I have excess tissue somewhere, and perhaps I need to do a better job of getting my tissue bound down so that when we convert, we won't have any holdups. The next step is to go ahead and be prepared to place our Neodent copings, or the Neoconvert copings, excuse me. I want you to clean and clear those with a plugger, with an explorer, and a suction prior to placing the copings. This way there's not any bone debris or potential blood clots that would form on the top of our multi-unit abutment platform. The next item that we're going to do is we're going to seat the copings with the capture pin driver. The mouth is a small place. It's hard to capture this video, but there you go. That's a clear shot. And we just turn. It will eventually, after a couple turns, I'll just go ahead and check to see if that they're on tight. We'll go ahead and watch that one more time. Here we are. We place the copings onto the multi. We'll spin. The driver will never get tight as it is going to continue to rotate after 1 to 2 Newton centimeters. So how do we know that the capture pin is all the way down? We're just going to feel if it's tight, and I try to rotate that clockwise, and it's on there firm and good. So we're going to go ahead and place all of our Neoconvert titanium copings on. What we're going to look for here is, can I see all of my Neoconvert copings? As you can tell, this Neoconvert coping in the posterior, I can only see the very top of it. I may want to consider trimming a little bit of that tissue, suturing it down so that more of it comes up, or just reevaluating that area. Perhaps maybe we need to use a traditional distal bar or a traditional coping on that one. And that's fine. That works with this Neoconvert system as well. You would just drill it out, unscrew the prosthetic pin, and then snap it off on your Neoconverts. What I want us to do next is we're going to try in the patient's existing denture. There's a little bit of sound here. I think this helps. I am just checking to get a good bite, seeing how both upper and lower come together. And I'm having a little bit of a difficulty here. And I can tell that perhaps the lower midline is slightly off. That is going to let me know that I have got a titanium coping somewhere that is binding onto the denture, and it is taking it away from where I want it to go from an ideal occlusion perspective. So we'll relieve the binding areas with the burr, as you can see here. My preference is to actually take away more of the acrylic denture base. In this way, I almost have a bar of my hookup material. So I'm a little more aggressive whenever we go through and make space for the Neoconvert copings. One thing that I have definitely found is that when you're ready for the conversion phase, if you will give some green lidocaine, the 1 to 50,000, that is going to help with hemostasis. I want to give this not only in the palate and not only in the posterior, but we want to really give this everywhere so I can get really good hemostatic control so that I have a high success of picking up every one of these copings. And as you can tell in this view right here, we can see the entire amount of our Neoconvert copings very well. One trick that I like to do before we place the acrylic in the mouth to hook up is I am going to pack the mouth with gauze and close it down and exert a lot of pressure and almost milk out any blood that could be residing within the palate or wherever underneath the tissues. Because when we convert this, there's going to be a little bit more pressure that the conversion prosthesis is going to place and give to the tissues, and that can squeeze out any blood, and that can run and inhibit a really good contact and adaptation of our acrylic hookup material and the coping. So pack that very nice and tight. Here we are. Once we have verified that the conversion prosthesis fits very well, we are applying acrylic in here. This is a Voco hard reline material that we're going to apply in the mouth, and we are also going to apply into the patient's existing prosthesis. Here I am hooking up both the maxillary and mandibular arches. I find that this works the best because I am able to align both arches at the same time and obtain the proper occlusion and have total control over the patient's occlusal plane and everything. And so That comes with experience. If you're under 150 to 200 cases converted, you may have a sizable time, and perhaps you should convert one arch at a time. Here I am, applying the resin. I get each arch seated, and then now we use maximum intercuspation to align and then place it into the patient's mouth. Oftentimes this requires some pressure from your fingers that are holding the maxillary arch, and it also requires some pressure from the thumb on the mandibular arch, lifting those together, and your index fingers are placed below the chin, and you are holding the jaw shut in the patient's CR. Where at this point we're going to pay attention to the occlusal plane, the cant, the midline, all of that to give a really good result. This material typically takes 5 minutes to harden, and once it does, I'll test it, make sure that it is hard, and then everything will just come out in a snap. I will typically use a Selden elevator because it requires a fair amount of pressure, downward pressure, to dislodge this. Here's a few mandibular considerations. One of the challenges that clinicians have in the mandibular arch is the amount of tissue that is mobile during and after the case. On 100% of my mandibles, we will drill a few transosseous sutures in between and distal to every multi-unit, and we will help secure. We will then attach the tissue to the bone so that it does not move. Here we are, we're lifting the tissue up. My 2O chromic is going through the first transosseous osteotomy over to the lingual tissue, being careful not to suture the sublingual or the submandibular ducts. We are then going to do this in a vertical horizontal mattress suture, and we will have the suture running through the bone, running through the tissue, and tightly adhering the tissue to the bone, and it no longer moves, and our Neoconvert copings now stand proud to the tissue. So we will repeat this 7 times on this patient's mandible, and then give it a watertight suture. So you can do individual interrupteds here, or you can do a continuous suture as I'm showing here. So now that I've got the transosseous suture, we will then work to now close this up, and as I run it from midline to the posterior, I will run it through the transosseous sutures as we encounter them and as we go posteriorly. Typically 1 suture per side. And again, this is a 2O chromic. If you want to learn more about transosseous sutures, come visit us and take one of our flagship courses at the Texas Implant Institute. Here, if you're watching the video, you actually saw that I went back through the same transosseous suture hole just to further secure and bind this tissue down more. We are continuing to run this further posteriorly through the other transosseous suture osteotomies. This does require use of longer needle tissue forceps and appropriately decent needle holders as well. And as we do this, we're taking very good care to make sure that all of the tissue stays and gets bound down. Here is the same case on the postoperative or post-suture shot. As you can tell, the Neoconvert copings are proud to every single one of those. Here is a post-op pano that we did. This patient required only 4 implants. And on the post-op pano, we're going to look to make sure that all of our copings are down and that it is locked in and it is secured. Here is another case where Neoconvert was done. We utilized 6 implants on this patient, and again, we're verifying that the copings are down all the way. And here is this gentleman's smile transformation. And as you can tell, with one procedure in one day, he looks amazing. And what a pleasure to be a part of this case and to be able to deliver this amazing smile. Okay, so let's talk about the lab work. Once this is removed from the patient's mouth, we are going to then rinse all of the saliva, all of the uncured resin off of the prosthesis. Oftentimes we'll use some Vaseline so that the sutures won't adhere to the conversion acrylic. And so we're just going to wipe all of that off because all of that is going to inhibit our ability to bond to it. Once the patient's prosthesis is clean, I want to run a nice thin layer of acrylic, sprinkle on acrylic, so it can fill any voids within the patient's prosthesis. And so this way I also get a very flat intaglio surface. We're going to place that in the pressure pot and cure it. After we do that, we are then going to remove any excess acrylic that may reside within the coping. And so that's what I'm doing right now, because we're going to want to be able to place our drill guide. And so if we have acrylic that is not allowing the drill guide to fully seat, then our screw access channels are going to be off. So as you can tell here, I'm verifying that we have intimate contact of the drill guide, and we want this for every single one of those. If you have some acrylic that's in there, just easily get it out with a rotary instrumentation. So once I know that the drill guide will fit, we are then going to use the 1.5 drill that we have, and we are going to engineer a screw channel that is highly accurate because of this drill guide. It has an intimate fit between the drill and the drill guide, and that is going to give us our screw channel. We are then going to drill that 100% of the way through until it exits out the prosthesis. So there I had a little bit of material that was keeping my drill guide from fully seating, and so to get the most amount of accuracy, we re-cleaned it out. Once the 1.5 drill exits out the opposing side, we're going to then switch our drills to the 2.0 drill, and we are going to fit that and run it backwards down from the occlusal anatomy down into the coping and through. And so this is going to allow a 2mm screw channel that will stop right at the coping. This 2.0 drill has a recess and a ledge, and so when you get to the metal coping, it won't actually drill through it. once you're all the way through, then just simply trim and polish. And as you can tell, this resembles a final prosthesis, and it looks remarkably amazing. Here's a complication we had on a case. A coping failed to seat all the way properly. Most likely, this is not just simply need to tighten this particular coping, because as you can tell, the anterior and the posterior implant appear to be fully seated. This is one that probably at the time of hookup did not fully seat, and we must have missed this. So how do we rectify this? We will just cut this out of the patient's prosthesis, and we will do a direct intraoral pickup with a salt and pepper method with a distal bar or something of that nature. This is another complication that we had. All 5 of our Neoconvert pins, Neoconvert copings picked up. However, the one that we had in the number 7-8 area did not pick up. So we elected to go ahead and send it to the lab, and we just did a chair side conversion pickup on that number 8 with a distal bar. Here's another complication. As your drills become more used, they can get dull. This is a picture where we were just going too fast. We didn't have all of the acrylic cleaned out of the screw channel, and as we kept going deeper and deeper, we went faster and faster. And what happened was the acrylic heated up, but then our drill speed slowed down enough to where there was enough friction that the acrylic actually cooled off and led to this seizing inside of our coping. So this is a little more of a challenge. We were able, luckily, to unscrew this and back it out. I've had this happen before where it's actually broken. Typically what I'll do is I will come on the occlusal side with a round burr, and we will just tear up and just eat away the metal until we'll just eat away the metal drill until I can back it out. I've not had a case where I've had to cut the coping out. We've had this happen a couple of times. It can also break inside your drill guide. We've had this happen once or twice, so always make sure that you have several drill guides available in your back pocket, to grab. Don't just order one. And guess what? We can use some scan bodies. We can use these reverse scan bodies with our Neoconvert pair. So on a case like this that we have designed digitally, we did an analog conversion. It's the only portion that was done analog. We designed it digitally, we analog converted it, and now we can scan this in our scanning software and then be able to make the patient a much stronger temporary prosthesis, or utilize this in a finalization. And so the beauty of this is it allows us to re-reference our preoperative design, bringing in the implant position. And so just other ways, as you do more and more all on fours, you will have cases where you do want to get back to, okay, what was the original design and where were the original teeth? If patients develop some phonetic issues post-operatively, this is really a great way to always kind of maintain where you were and how to kind of get back to the patient's baseline. So dentistry is changing today. Full arch dentistry is changing so much. We are in such a better time now than where we were. So, thank you all for listening. If you want to know more about this, we present this in our full arch flagship cadaver course with the Texas Implant Institute. So check us out online, www.texasimplantinstitute.com, and would love to see you at a future course. Thank you all, and have a good night.